So our next panel of speakers will focus on communicating risk and uncertainty in the clinical setting. Our moderator is Lori Francis, one of our members of the roundtable. Lori is the Senior Director of Clinic Operations and Quality at the Oregon Primary Care Association. She's also the founder of a community health center and has worked for over 2 years to improve the health and well-being of individuals and communities trying to achieve the now quadruple aim. She is also a member of the roundtable, as I mentioned. Lori?
Thank you, Bernie. We're excited to have another great panel up here, and I know you guys will enjoy it as well. I understand in talking to some of the staff for the roundtable that it was difficult to find people who incorporated health literacy in this topic, so we're very lucky to have you all here. The first speaker on this panel is Dr. Lori Erby, who is the Associate Program Director for the Johns Hopkins University National Human Genome Research Institute Genetic Counseling Training Program and an adjunct assistant professor in the Department of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. She's been practicing as a genetic counselor for almost 15 years and has been continuously involved in research and training efforts aimed at improving communication practices as genetic and genomic technologies evolve. She will be speaking on communicating for understanding in the clinical setting. Second, we have Dr. Jessica Anker, who's an associate professor at the Healthcare Policy and Research at Weill Cornell Medical College. She began her career as a journalist before earning an MPH and a Ph.D. in biomedical informatics. Her expertise is in health numeracy, patient decision-making, and health technology evaluation research. She will be presenting on communicating risk to low health literacy populations. Our first reactor for this panel is Dr. Terry Davis, who is a professor of medicine and pediatrics at Louisiana, I heard you say at lunch, Louisiana State University Health Sciences Center in Shreveport. Sorry, I tried. She's a member of the Roundtable on Health Literacy. Our second reactor is Kathy Wicklund, who is the director of the Graduate School in Genetic Counseling at Northwestern University and an associate professor in the Department of Obstetrics and Gynecology. She's a member of the Roundtable on Translating Genomics-Based Research for Health. As with the morning sessions, please hold your questions until after everyone has spoken. Dr. Erby.
See,
Is the clicker up there on the table?
is it back on? Ah, yes, thank you. Sorry about that. Jessica and I both decided we would rather stand, so we're gonna do it this way. So thank you so much for inviting me today. This is a topic that's near and dear to my heart, and I just thought I would give you a bit of insight into how my talk will be colored, because I, as you heard, I'm a genetic counselor by training. I trained in this part of the country, and through my clinical observations as a trainee, I became very enamored with the idea that we really needed to know a lot more about how to do a good job communicating about these really complex topics. So ended up getting sucked into a PhD program where I then spent the rest of my life studying patient-provider communication in this context. And it just serendipitously so happened that as I was defending my dissertation in 2005, it was only a year after the Prescription to End Confusion was published, and there was a big push toward thinking about health literacy, and that really has colored pretty much every question I have asked since then. So in the 15 minutes I have today, I'm going to give a very broad overview of some of the things that I think about when I think about what constitutes good clinical communication, and I hope it leads to bigger conversation. So the three main themes that I want to sort of carry through my time with you this afternoon are that verbal communication presents a challenge for individuals with limited health literacy. That will be no news to anyone in this room, but I think is important to have as a context when you're thinking about verbal communication in the clinical context. That information related to multifactorial disease is particularly challenging as we start thinking about the role of genetics and trying to think about that laundry list of elements that might go into a person's precision medicine calculation at some point. That is a very complex communication context, and that all the things that we've learned about communication more broadly are even more important given that additional complexity. And then finally, that there is evidence already that exists to support specific communication interventions about good communication practice that could be important in a health literacy environment. But I'll preempt myself a little here by saying, even though evidence exists, I would push us to be thinking a lot about the extent to which we want to think about precision communication alongside of precision medicine, whether a one-size-fits-all list of techniques is really what we want to be working on, or whether we actually have an opportunity now to be doing more than that. So this is a figure that will be, none of you are a stranger to, that came out of Howard Koh's model around more organizational health literacy. And I put it up here just because I wanted to situate myself that I'm really in this bottom center box thinking about productive interactions being a big part of the organizational system. And although I buy into the entire model, today I'm focusing very narrowly on that piece. So let's start out with my first theme, which is the idea that verbal communication is actually challenging, even if you don't have to read a thing, that health literacy matters in the verbal exchange. And we've known about that this is a problem for many decades at this point. Focus group studies with patients who had lower levels of education or who had difficulty managing their health care would consistently come up with themes that would show that people felt like they couldn't understand what was being presented to them, even if it was being told to them, even if they were having somebody directly speak to them, they really didn't feel like it was accessible information. And then you would also find that interventions that were put in place where we'd say, well, let's just have a class and teach people verbally the things that we want them to know, and that should fix the problem. They don't need to read anything, we'll teach it to them, and that people would still have lower levels of health knowledge even after these verbal exchanges than we would expect, and so therefore that was giving us some inclination that in fact this was a problem. We also would hear from focus group studies that people felt like they weren't able to communicate well with their healthcare provider, so they felt like they weren't being listened to, and maybe some of that was related to the fact that the provider was actually not asking to hear their story, but some of it might have also had to do with their own ability to express themselves. So these are all things that gave us an inclination that this needed to be looked at further. And so now that we have a body of literature to look at, if you actually measure somebody's health literacy using the imperfect measures that we have and correlate that with how well they learn within the medical context, we can see that in fact individuals who have lower levels of literacy do learn less from verbal exchanges. So this is a figure from some of my work, but there have been other studies in other contexts. I include this one not only because it's mine, but because it's in the genetics context, so it's particularly relevant to what we're talking about today. And what you can see from this study is we had people watch a video of a genetic counseling session, and we had two different sessions that they could be randomized to. One was a fairly standard prenatal genetic counseling session, and the other, just to give a sense of context, was a cancer genetic counseling session. And in both settings, people who had lower levels of literacy had lower levels of knowledge at the end. Now, I will point out, oh no, I turned it off. Okay, thank you. So that everybody, even those with higher levels of literacy, had at most 50 to 60% knowledge on their knowledge scores at the end of this exercise. And these were actually not particularly tough tests that we were giving people. We had devised them to be, these are the main 5 points we would want any patient to know at the end of this genetic counseling session. Did they get them or not? And in fact, even those with high literacy skills didn't perform as well as we would have hoped. So this tells us something about this communication encounter in this context, that it's difficult for people to learn in this context. But people with limited literacy skills struggle even more. So given that observation that we had, my close colleague Deborah Roeder and I spent a little time thinking about, well, how would we begin to look at the communication exchange in a way that would allow us to have some insight into what might be difficult for a person who has limited health literacy skills when they're encountering this context. So we, based on the really smart and long-term work of Lynn and Cece Doak in the print world, decided to look at elements of the verbal exchange that might be parallel to the things that we typically look for in the print materials that might make them difficult. So we decided we would think about things like technical terminology or jargon, the use of that kind of language in the genetic counseling visit. General language complexity that goes beyond just jargon use, but complex sentences, overall multisyllabic word use, even if it's not jargon use. Dialogue pacing and interactivity. So this was our parallel to Doak and Doak's idea that you want to chunk information that people need to be engaged with the print material. And we thought, well, likewise, in the verbal exchange, people might learn better if they're interacted with, if they're engaged with, and also if you're chunking information into smaller bits. So we wanted to look for that. And then the grayed out box was the box that we also thought was important, but that we still are working on how we want to best operationalize it. So this idea that concept density, the sheer amount of information you're trying to convey in one setting is probably very important. And then also how that information is contextualized, both in terms of whether it's presented in a personalized way versus a very generic way, and whether there are other elements of the communication, the content itself, that might make it difficult. And that is the piece that we haven't actually, you'll see from the following slides, we haven't done as much with at this point. So given this framework, we decided to delve into the study that we were currently doing and look at whether we could apply this framework to our genetic counseling communication visits. And we looked at jargon use, and we had a measure that we use of jargon use, and we've published on that. This figure is actually from an ongoing study, and I like it because, for a reason I'm going to tell you, this gives you a sense of jargon that came out of one specific transcript. And it's very indicative of what we've seen from lots of transcripts in this study, and it's a study that we are doing right now in conjunction with my collaborator, Robert Green, who does work in risk evaluation for Alzheimer's disease. And this study was done in the context of individuals who have mild cognitive impairment and who are facing risk for going on to develop Alzheimer's disease, and are being either given genomic information or being given risk information that's not related to their genomic risk. And so these are words that came out of their results disclosure session. And the reason I put this particular study, an example from this study up here, even though the study is ongoing and I don't have numbers to share with you, is that this study was actually very carefully crafted, and it's very standardized. So the communication is very well thought through in terms of what concepts are going to be disclosed in the results disclosure visit. People are highly trained. There are genetic counselors who are largely doing the communication, and there's still lots of variability and when you audio tape them and see how it actually plays out. And you still see, even with this very well thought out procedure, lots of jargon use across the visit. So this is, again, these are all words that came out of just one visit in this one results disclosure. So we get a sense that there's lots of jargon being used in this genetics context. In terms of looking at the elements from our conceptual framework, we wanted to see whether they might link to any outcomes that we care about. And this study was a simulation study. So we had the simulated patient satisfaction, which is an imperfect measure, but we also went ahead and had people that we considered analog patients be randomized to watch the genetic counseling sessions. And then we collected satisfaction data from them and also knowledge data, which allowed us to see whether there was anything in the communication that then linked to their knowledge. And I would say these are tenuous links because these are very hypothetical and these people are not personally engaged, but it still gives us some insight into what might matter. So this might not be shocking. The simulated patients actually were quite affected by the things that made language complex. They didn't like it when people used a lot of genetics jargon. They didn't like it when there was generally overall complex language. And they loved it when the genetic counselor was more interactive with them. But these standardized patients all saw, on average, 30 different genetic counselors. So you can imagine that over time it would be more engaging and more interesting to have, and then you could compare between them. So that this actually doesn't shock me. In the next column, when you look at analog patients, you actually don't see much effect in terms of satisfaction. They were generally pretty satisfied with everything that they watched. They didn't have that point of comparison. And it was true for both the lower literate analog patients and the higher literate analog patients. There just weren't any significant associations with satisfaction. But when you look at the analog patients' knowledge after watching the video, if you look at the LL column, which is the patients who scored as having lower health literacy, you can see the biggest, most significant effects are in terms of interactivity. So the lower literate clients or analog patients tended to learn more when there was more interactive sessions and when the information was more personalized. So that was the contextualized fact. They learned better, and that's what we would have imagined. And they tended to learn a little worse when there was high language complexity, but that was on the, it was only at the 0.10 level, so we weren't really reaching statistical significance with that. The thing that's really interesting and that I think will further conversation is if you look at the other group of patients, the ones who scored as higher on our literacy measure, The opposite interactivity effect was observed. So people actually learned worse when they were assigned to a video where it was very interactive. And that was completely counterintuitive to us. And I have ideas about why that might be, but we haven't tested them yet, so we can talk about that after. But it does tell us something about how much, when I say we need to have precision communication, we really do need to think about what are the characteristics of the people that we're communicating with, because it does matter. It might actually matter quite a lot in terms of their ability to comprehend. The way in which people learn is different. This is another study that was done in follow-up, not by my group, but just, again, trying to extend this idea of can we capture elements of literacy demand and visits, and how do physicians or healthcare providers talk in comparison to how family members might talk. And this study actually looked at the two participants in parallel and characterized their language, and found, as we might have expected, that the physicians in the study spoke with greater language complexity than the patient's family member tended to, and that they tended to use more words per turn, so they spoke in longer turns. That's probably not surprising, but gives us a sense maybe that that there is some imbalance there. So moving on to my second quick point was that this is a particularly challenging context. So I've been talking a lot about literacy demand, and I gave you genetics examples, but I think that those characteristics apply across the medical spectrum, not just when you're talking about genetics. But the fact that we're starting with the Precision Medicine Initiative to think about how communication might matter as you move into looking at multiple factors altogether and trying to communicate that, including genetics, but environment and lifestyle and a lot of other different factors together, that's a very dense conceptual place to function in. And that the way in which the patient and the provider both function in that environment is really important. We know a lot in terms of how patients understand genetic information in particular, and we know that there are difficulties in understanding genetic information. And we also know that how people apply genetic information as well as other information to their decision-making and their action steps is going to be very tied to their personal values. And if where we ultimately want to go with precision medicine is to not just inform people of their risks, but help them act upon those risks, we need to be thinking in our communication about how what we're telling them fits within their own system of values. The provider piece is also important, and I raise it here in particular because as we start moving again into more and more genetics and genomics, that we're talking about providers who haven't been classically trained as geneticists, and for whom we know from the research literature have some level of discomfort talking about genetic and genomic risk. And although there's been lots of work, as Joe McInerney talked about early this morning, to try to help educate the health professionals and give them the knowledge that they would need to be able to function in this environment, just the fact that there's discomfort is going to affect the communication process. As anybody who's ever trained trainees knows that even when you've helped people become good communicators, that when you put them in a place where they're anxious and uncomfortable, that they don't perform to their maximum ability. I'm going to end talking about the fact that we do, as I said, have evidence that exists to support specific communication interventions. And these are the universal precautions from the AHRQ that you're all probably very well aware of. And I've highlighted in red those that how well they correlate onto our framework in terms of thinking about plain non-jargon language, thinking about limiting content, so chunking things. Repeating content is also considered very important. Inviting patient participation, so the interactivity piece, all of these are there. And we have evidence that these things work and lead to better knowledge. But what we don't have very much of, so there's only still at this point in time a very limited a body of literature that relates actual variation in communication practice to actual patient outcomes. And as we move into these more complex scenarios where people are going to be trying to think about multiple different kinds of risks in one place and trying to think about how that fits into their overall lifestyle in very important ways, that we may need to be thinking about how all of these might apply differently in specific contexts. So again, my call toward wanting to move toward more precision medicine, thinking about whether there are novel techniques that we haven't tried out yet that might help to further enhance understanding, because as I showed, we still, even using these mechanisms, don't reach the highest levels of comprehension that we might want. So really pushing ourselves to think about whether this is an opportunity, as we're bringing in 1 million people, to then also study different communication contexts and how we might improve them. I included this just to show that even genetic counselors, who one of 4 domains of their practice is to actually focus on interpersonal psychosocial and counseling techniques, but that's 1/4 of the domains of learning from a genetic counselor's standpoint, that even then, if you look at the specific competencies, we're talking very generically about facilitating informed decision-making, and helping meet clients where they are, matching their needs. But there's nowhere in the competencies for genetic counselors where we talk specifically about health literacy, and that is certain to impact how we as educators think about training from a communication standpoint. So that I thought was just an important point to end on before returning to my final themes, which are that verbal communication presents a challenge for individuals with limited literacy, and perhaps for all of us, for everyone, that information related to multifactorial disease is particularly challenging, and that we might need novel methods, that we really need to take advantage of this opportunity. And then there is, although we do have evidence, we still need to build on that body of literature and think about how that will also influence training of providers. And with that, I thank you.